Is it visible, sir? Hello?
Yes, it's visible, Yugal. You can proceed.
Okay, sir. Good evening, sir. So today from this topic, we are just try to understand the evolution in the diagnosis as well as the treatment strategies and the various factors involved in the rotator cuff repair. So as we know, a rotator cuff is a important structure which provides the fulcrum to the deltoid, and it is important for the shoulder function. So its surgery is very common nowadays. It was first described by Alexander Monro in 1788 as a tear in supraspinatus and infraspinatus. You will be surprised to know that almost for a century, after a century in 1880s, the Cronlin and Berdenhauser, they suggested there is a possibility to reattach the rotator cuff tendons, that too in chronic dislocation cases. This was a landmark year, 1911, when Codman first described the surgical technique to repair supraspinatus tendon using the heavy silk sutures with the end-to-end suturing. Arthroscopy, it actually gave more clarity in the treatment of the ligaments. First, Takagi, the Japanese orthopedist in 1918, he used the cystoscope to examine the knees. It was Wanabe in 1967 who used the fiber optics in the arthroscopy. In 1931, it was the first time when Berman did the shoulder arthroscopy, that too on cadavers. The first open rotator cuff repair for retracted lesions, it was described by McLaughlin in 1944, in which they used to do the deltoid detachment from the acromion and the AC joint. In 1943-44, again, Smith, Peterson, and McLaughlin, they came with the concept of acrominectomy. Thinking like subacromial abrasion, it is one of the elements in rotator cuff disease. In 1972, again, Neer came up with the idea of acromioplasty to reduce the supraspinatus wear and tear. Till this 1972, it was always an open procedures for the rotator cuff. It was in the year of 1987 when Ellman presented a large case series of arthroscopic subacromial decompression, following by which Rockwood in 95, he did the debridement and subacromial decompression for irreparable rotator cuff tear. In 1990s, Howard J. Levy, he first described the arthroscopic assisted mini open rotator cuff repair. So arthroscopically, we used to do the diagnosis, subacromial decompression, and cuff tissue was mobilized, and then open repair with a deltoid split, not with the detachment. It was in 1993 when Schneider did the first arthroscopic rotator cuff repair, that was single row repair. In 1993, Burkhardt came with the concept of suspension bridge or partial repair of the margins with minimal tension to restore the force couples and facilitate the force transmission. It can be considered even in massive tears with chronic retraction. 2002, Fenlin described a technique open tuberoplasty. It means removing the exostosis on humerus. It reshapes the greater tuberosity and gives a smooth, congruent acromiohumeral articulation. It was indicated in elderly patients with irreparable tears. The only disadvantage with this technique was the acromiohumeral distance it decreases, which may lead on to glenohumeral joint osteoarthritis later on. Coming to the irreparable retracted cuff tears, complete repair can be achieved through certain techniques such as interval slide, margin convergence, or medialization. All these techniques, they reduces the tension on the tendon, they minimizes the gap formation and restores the normal kinetics. Interval slide was for the first time described by Bigliani in open surgery, following which 1999 Toro described the arthroscopic interval slide, in which they released the torn retracted supraspinatus tendon from the rotator interval. 2004, Lowe and Burkhardt, they came with the concept of anterior interval slide and posterior interval slide. The concerns with interval slide is supraspinatus devascularization, high retear rate, and the final outcome is not very much advantageous over partial repairs. 2004, Burkhardt described the technique margin convergence for the large U, L, or reverse L-shaped rotator cuff tears. It decreases the gap formation and restores the range of motion, restores the kinematics. If necessary, it should be performed at muscle tendon junction to increase the biological healing of the cuff. Medialization was another technique which for the irreparable retracted cuff tears, and it is advisable to medialize it up to 10 mm from the footprint. In 2003, means just 17 years before, the double row arthroscopic rotator cuff repair, which is very common these days, was described. It uses medial and lateral row anchors. Both row suture wires, it separately pass through the torn rotator cuff and attach to the footprint. Double row is biomechanically superior than the single row as it covers more footprint, improves the structure healing, and it gives better clinical outcome. Open arthroscopic transosseous rotator cuff repair. Previously, we used to do it with the help of giant needles, but in 2006, Nicholas Mattis and Nicola Sikak, they gave the device for arthroscopic transosseous repair. Transosseous equivalent was described by Maxwell C. Park in 2006, in which medial row of anchors were inserted at the articular margin. After repair, the sutures were not cut, but the suture limbs, they used to create suture bridge over the tendon, and it used to be fixed in the lateral drill hole with the help of a push lock anchors. In case of irreparable retracted cuff tears, there is a concept for graft augmentation to cover up the gap. Patch graft is used. It could be a xenograft, synthetic material, or any allograft. Biceps augmentation was first described for the irreparable retracted cuff tears by Nevieser in 1971, long back, which prevents superior migration of humeral head. It gave the clinical improvement, but there are little high chances of re-tear in that. If it's irreparable massive rotator cuff tear in young patients with no arthritis, tendon transfer is a good technique. It restores the force couples and normal kinematics. It was first described in 1980s by Cofield with the subscap transfer, by Gerber, by latissimus dorsi. Other muscles tendons which can be transferred are pec major and lower trapezius. In 2007, Gervasi, he was the first to do the arthroscopic leg dorsi transfer. Superior capsular reconstruction, again, it is used for irreparable retracted rotator cuff tears in elderly patients without severe osteoarthritis. Superior capsule usually gives a superior stability of joint in conjunction with rotator cuff. For successful outcome in SCR, acromioplasty and repair of infraspinatus subscap is necessary. Normally, the tensor fasciator graft is used for this. So once it is harvested, it is doubled or tripled the size of the defect, and then it is inserted into the subacromial space, where it is attached medially to the superior aspect of glenoid tubercle with 2 suture anchors, and laterally to greater tuberosity with 1 suture anchor. For successful outcome, it is attached anteriorly to the subscap and posteriorly to the infraspinatus. Spacers, biodegradable spacers are also used in irreparable cuff tears made up of copolymer. Once it is inserted into the subacromial space, it is inflated with saline. It widens the acromial space to avoid the friction in between the humeral head and the acromion, which reduces the pain and restores the biomechanics. Last, irreparable massive rotator cuff tear with advanced orthoarthritis in elderly patients, or if the patient is pseudo-paralytic, hemiarthroplasty and reverse total shoulder arthroplasty can be done. So reverse total shoulder arthroplasty, it medializes the center of rotation, lateralizes the fulcrum, it increases the deltoid function, which improves forward elevation, but it does not improve the rotations. and there are very lot of complications related to the arthroplasty. So it is not advisable every time. It is kept always as a last resort. Suture anchors, they also evolved from like in 40 to 50 years, starting with the metallic anchors, then non-metallic, used made up of PEEK material or polyglycolic acid. Nowadays, we are using the all suture anchors made up of ultra high molecular weight polyethylene. So seeing this evolution, we came to the treatment protocol. What we normally follow is we divide the patients in 3 categories, which have repairable rotator cuff tear, repairable at risk, and irreparable. Repairable rotator cuff tear patients undergo single row, double row, transosseous or transosseous equivalent procedures, whereas irreparable rotator cuff tear, if it's in young patients, tendon transfer is a good option. If it's irreparable in elderly patients without much osteoarthritis, superior capsular reconstruction can be done. If there is a arthritis, glenohumeral osteoarthritis is there, then we can directly go ahead with the arthroplasty. The main problem with is the second category, that is repairable at risk. So normally we try to do the complete repair or with the certain techniques such as interval slide, marginal convergence, or medialization. So rotator cuff repair, its understanding is still evolving. Even we have got a lot of techniques, a lot of good implants, but still the biological healing of the cuff is still controversial. The judgment of the rotator cuff repair and the patient, it varies in all. So we have to do the proper clinical evaluation, we have to rehabilitation, and we have to individualize the treatment according to the patient. Should be followed as a la carte approach. Thank you.
Thanks, Yugal. You can stop sharing your screen.
Yes, sir. Thank you, sir.
That was nicely covered, the history of how this cuff evolved. And I think when compared with other conditions, there are more concepts and more techniques involved in the rotator cuff tear, in any other surgical technique as far as arthroscopy is concerned. Chandrashekar, would you like to add your comments on this?
I think Yugal has covered it very nicely, sir. I don't think, I mean, we have to add anything more. What his slide preparation is very meticulous. That he has shown how the evolution is and what are the current practice and what are the concepts behind the practice now. Probably during my lecture, I will add a few more points to his what he said actually.
Okay. So any questions in the chat or Q&As? Great.
Coming to the question of reverse shoulder. In reverse shoulder, we usually reserve it for patients with rotator cuff arthropathy, wherein the patient has a massive irreparable tear with arthritis. But of course, in certain elderly individuals like who's 70 above, 65 above, 70 above, especially 70 plus, where patient has a massive irreparable tear and he got a complete pseudoparalysis. So probably that patient, sometimes we do a reverse shoulder directly, because coming to the question of doing superior capsular reconstruction, which I'm doing since last 4 years now, it is even though the original surgeon who has described this superior capsular reconstruction, Dr. Mehta, has told that he has shown in some of the research papers that even pseudoparalysis can be reversed, but it's still debatable. Pseudoparalysis because of pain probably can be reversed with a superior capsular reconstruction, but pseudoparalysis without pain, a complete total pseudoparalysis wherein the patient will not have any elevation at all, a total pseudoparalysis, probably, especially in elderly individuals, probably is a difficult task with a superior capsular reconstruction. So either in elderly individuals, we can have two options: do a partial repair and give him some pain relief and some elevation and leave it to that, or else you do a reverse shoulder process, give him good elevation and good pain relief. Till now, I have done only one patient with a pseudoparalysis treated with their superior capsular reconstruction. All my patients, I did superior capsular reconstruction when they have 90-degree elevation. When somebody has pseudoparalysis, complete pseudoparalysis, I have never done a superior capsular reconstruction. But recently, I have done in one patient who is young, who is around 38 years old. So I cannot do a reverse shoulder in this patient, particular patient. Even though it's pseudoparalytic, I tried superior capsule reconstruction, and fortunately doing well. He got almost 170-degree elevation. But I'm not sure the same thing works in an elderly individual, because in a young individual, the deltoid can be retrained, and a strong deltoid can compensate to a certain extent of loss of cuff tear, and probably they can get good elevation. But in an elderly individual, the deltoid may not be having so much of strength, and probably it cannot compensate for the loss of the cuff tissue, and for which a reverse shoulder is a better option.
What is the role of subscapularis tendon status to decide whether you want to go for reverse or superior capsule reconstruction?
I have done superior capsule reconstruction in patients with subscap tear, but provided they are repairable. So I have done, the patients had a subscap tear also, and I have repaired the subscap first, then did a superior capsule reconstruction. Those patients are doing well. I had 3 patients like that. But I haven't done any patient with irreparable subscap tear. I haven't tried a superior capsule reconstruction.
Okay. How about the interval slides? Is it out of favor now, the posterior interval slides?
Interval slide, I never did it, sir. I never did interval slide. I did anterior release always, which is, I don't know whether you can call it as an anterior slide or you can call it as a coracohumeral ligament release, what we do routinely to mobilize the supraspinous tendon from the coracoid. But I never did a post-anterior slide. I believe it is non-anatomic. And as Yugal has pointed, it's a high failure rate, high retear rate. And most of the times, if you spend your time in proper releases, that extra-articular release and intra-articular releases, and this coracohumeral ligament release, majority of times you can mobilize your tendon. Yeah. And if not, I medialize a little bit, and then I do a single toe repair sometimes.
Chandrashekar, there is a question from Bhupesh.
Yeah.
Who is the ideal candidate for lat dorsal transfer?
Lat dorsal transfer, a patient, probably, I mean, not elderly, even though in Western countries, they do even for 75, 80 years old patients also. I never done it in elderly individuals. I did it for less than 60 years, never above 60 years. And especially I prefer to do it in males, because the tendon, what is the strength of the tendon, or the quality of the tendon and length of the tendon are slightly better compared to females. Even though I did it in 2-3 females, I prefer to do it in males. And those who have 90-degree elevation, at least. I never, send contraindication to do a latissimus dorsi transfer for a patient with pseudoparalysis. So a patient with the irreparable cuff tear, especially the posterior superior cuff tear, that means supraspinatus infraspinatus, with 90-degree elevation, and who is weak in external rotation, like that hornblower sign, is an ideal candidate for a latissimus dorsi transfer. But nowadays, with the advent of superior capsule reconstruction, which is an arthroscopic technique, I mean, all arthroscopic technique, not like arthroscopic assisted latissimus dorsi transfer, which is partly open, partly arthroscopic, and superior capsule reconstruction, which is an arthroscopic procedure. Especially if you use a dermal graft, you're not given incision on the thigh also. You can use a dermal graft or allograft directly. Wherein even these patients with 90-degree elevation also can be taken for superior capsule reconstruction. And probably nowadays, the ideal indication for latissimus dorsi transfer is that patient who has loss of external rotation and who is like middle-aged and working, can doing some kind of work where you can give him some external rotation strength. Loss of elevation can be treated by latissimus dorsi or superior capsule reconstruction, but loss of external rotation is better treated with a latissimus dorsi transfer.
Okay. So we'll move on to the next talk. Probably there will be a lot more questions at the end of the technical lecture. So Chandrashekar, can you start sharing your screen?
So I thank Dr. Clement Joseph for inviting me for this particular webinar, and thank Biotek for inviting me. And I'm going to speak on rotator cuff repair technique and some tips. I'm Dr. Chandrashekar. I'm a consultant shoulder surgeon at Sunshine Hospital, Hyderabad. So as Dr. Yugal has spoken in detail, we do nowadays, we finally have come to arthroscopic repair, of course, not mini open or open. And the majority of us doing only arthroscopic cuff repairs. It can be a single door repair or a double door repair. The standard technique we do, or most of us do, is a transosseous equivalent repair with a double row of anchors. But sometimes we do a single door repair. Number one is a small to medium sized tear, especially in elderly individuals, low demand individuals, you can do a single door repair. But large tears, massive tears, whenever they can be, whenever they can be released properly and reduced back to their footprint, and especially younger individuals, ideal to do a transosseous equivalent double door repair, which has higher healing rates and better functional outcomes. Position, either you can choose to a B chair position, or you can do a lateral decubitus. I do it in a B chair position. And of course, I know that Clement Joseph does it in a lateral position, which is your depends on your training and your comfort. And traction, it's always useful in rotator cuff repair. And when I use a simple pulley traction in B chair, like that upper top right side picture here. And then you can use a commercially available hydraulic arm position like a spider, or you can use a Tremano, which is a hydraulic arm position, and which can be used to give some traction for the humeral head. And in lateral position, you can use a commercially available triple traction, or you can use a custom-made lateral traction. Now coming to portals, I use 4 standard portals: the posterior portal, posterolateral portal, anterolateral portal, and anterior portal. And I use the anterolateral portal and posterolateral portal for both viewing and also for for the instrumentation, and posterior portal and again for viewing, and anterior portal for instrumentation. You see here, this is the posterior portal, is a standard, maybe slightly superior in lateral compared to a posterior portal which you do for Bankers repair, and the posterolateral portal and an anterolateral portal and an anterior portal. And then if you see, there are 2 small portals here, the accessory portals near the lateral border of the abdomen. These accessory portals are for the insertion of the medial row of anchors. When I do a double row, I use these portals for the medial row anchor insertion. Of course, the anterior medial row anchor can be inserted through the anterior portal sometimes, but sometimes it's a little difficult. So then you can use an accessory portal. But the posterior medial anchor is usually inserted through an accessory portal always. Now, you have to understand the most important point here is that the accessory portals for the anchor insertion should be as close to the lateral border of the abdomen possible, so that you can have a good angle of insertion of the anchor. Now, when you want to repair a rotator cuff, the goal is three-point goal. Number 1, you want to do an anatomical repair, and you want to do a tensionless repair, and you want to do a strong repair. Now, an anatomical repair is the repair where you have to reduce the tear as per the tear pattern. So first of all, you have to identify the tear, what shape of the tear is, and then reduce it accordingly. And then you want to do a tensionless repair. That means we release the tendon and the musculotendinous junction units from their surrounding tissues properly, and then bring it back onto the footprint without any tension. And then you want to do a strong repair. Of course, biomechanically speaking, a transosseous repair or a transosseous equivalent repair with anchors is the most stable repair, which gives you which won't fail with cyclic loading in the post-operative rehabilitation. So anatomic repair, I mean you would identify the tear pattern and reduce it accordingly. That means fix it where it belongs. Okay. Now, if you have different tear patterns, one is a crescentic tear pattern, where if you see here on the top left corner, you have the tear looks like a crescent, and when you hold the center of the tear and pull it laterally, it can be reduced onto the footprint. Whereas on the top right corner, again, you have a tear which looks like a crescent, but when you hold the center of the tear and pull it laterally, it won't get reduced. It's called a U-shaped tear. Here, what happens is, instead of the center of the tendon, if you hold the anterior leaf of the tendon and pull it posteriorly, it will mobilize. And again, if you hold the posterior leaf and pull it anteriorly, it gets some mobility. This is a chronic retracted U-shaped tear, what we call the massive retracted tear usually. So in this scenario, what we do is that we put some side-to-side stitches in the anterior and posterior leaves and convert it to crescent shape, and then repair the crescent by a single row or a double row, depending on the situation. Again, you have a L-shape or reverse L-shaped tear, wherein one of the leaves of the tear are not mobile, are mobile only, have little mobility, whereas the other leaf has more mobility. Now we see a reverse L-shaped tear where the anterior leaf can be pulled posteriorly, and you have to hold at the proper point. That's what is called apex. You hold at the apex and pull it posteriorly, and it will get reduced well. And now we have a vertical component, horizontal component, or a longitudinal component, horizontal component tear. The longitudinal component, you can put some side-to-side stitches and then convert to a crescent shape and then repair the crescent tear. Again, L-shaped tear, where the posterior leaf has more mobility compared to the anterior leaf, and this can be pulled, and again, you put side-to-side stitches and convert to a crescent shape, and then repair the crescent tear afterwards. Finally, what I have to say is that, what are the type of tear? You do the necessary side-to-side stitches if necessary, and then convert it to a crescent shape, and then repair the crescent shape with a simple single row or a double row fashion. Now, this is a crescentic tear. This is a video given by Dr. Bhupesh Karthik, my friend. And if you hold, the center part of the tendon and pull it laterally, it can be reduced very easily. So this is a crescent-shaped tear. Hold the center of the tear and pull it laterally. Now, unlike this one, this is a U-shaped tear where I would put side-to-side stitches from the anterior and for the anterior and posterior leaves. You will see here, the suture is passed from the anterior leaf. Now it is passed through the posterior leaf of the tear, like this image here. And then you tie these sutures and convert it into a crescent shape. Now this video shows a single side-to-side suture, but sometimes you have to put 2 to 3 side-to-side sutures to convert it into crescent shape. Once it is converted into crescent shape, then you can pull it laterally and see the mobility. And once it's reducible, you proceed with the repair of the crescent with a single row or a double row. Now, this is a reverse L-shaped tear, wherein if you see, we hold the anterior leaf and pull it posteriorly, you can reduce it nicely. Now, this is the apex of the tear actually. This is the apex of the tear. Okay. Now, there is a longitudinal component. This can be repaired with a side-to-side stitches. And then this crescent, the crescent shape that was left to the last can be repaired in a standard fashion. Now, this is the standard or the routine, this is a routine tear we see. The posterior superior cuff tear, which involves the supraspinatus and part of the infraspinatus, which is the commonest type of tear pattern we see. This is the intraarticular view. You can see the tear, and there's some partial tear along the biceps also. And this is the bursal view. You can see this is the infraspinatus tendon. It's a delaminated tear where you have two laminae of the tendon, and the anterior part of the tear. It can be pulled laterally, but not without tension. So that means we have to do some releases before we can proceed with the repairs. Now, the first thing I start with a bursectomy. I clean the bursa properly. I keep my scope in the anterolateral portal and use the instrument from the posterior portal or posterolateral portal and expose the especially the posterior rotator cuff and the musculotendinous unit. And by debriding this bursal tissue, I can use a shaver or I can use a radiofrequency ablator. And usually, if you use the instrument away from the cuff, it is safe. But sometimes you have to use the shaver or the radiofrequency ablator on the cuff tissue also. But in this case, you have to be a little careful and gentle not to damage the muscle or the tendon unit here. Now, this is the bursectomy I'm doing here, exposing the posterior part of the rotator cuff. My scope is in the anterolateral portal, and the instrument is coming from the posterior portal. And then I do 3 releases standard. Those releases are, first one, I release the rotator from the superior surface. That is, I release it from the spine of the scapula, from the supraspinatus and infraspinatus fossae. Now, this is the spine of the scapula, which will be seen like the keel of a boat. And this is the supraspinatus tendon, and this is the infraspinatus tendon, muscular unit junction unit actually. And you can go up to the keel of the spine of the scapula, and not medial to that because you have the suprascapular nerve going there. So you can go till this junction, and here you can see this is the infraspinatus muscle fibers, and if you see carefully, you will have the supraspinatus muscle fibers anteriorly. So till that level, you have to release it, and then the next release is intraarticular release, or what we call the capsular releases. We release the musculotendinous junction units from the posterior glenoid and the superior glenoid. Again, you can use a radiofrequency ablator, or you can use a banker's nerve kind of device. But when you are releasing to the superior glenoid, don't venture beyond 1 to 1.5 centimeters beyond the superior glenoid, because the suprascapular nerve will be coursing there. So when you're releasing the superior glenoid, you have to be a little careful, and you don't go beyond 1 centimeter from the superior glenoid, the bony glenoid. Now, once I do that, I do the third release. The third release is from the coracoid, and usually release the anterior supraspinatus from the coracoid, and what we call the coracohumeral ligament release. So this is the lateral part of the coracoid here. I release the lateral part of the coracoid and the undersurface of the coracoid. This increases the mobility of the anterior supraspinatus. So these are the 3 standard releases I do. Well, number 1 from the spine of the scapula and the supraspinatus and infraspinatus fossae, and number 2 from the glenoid, from the posterior glenoid and the superior glenoid, and then number 3 I release from the coracoid, from the lateral and undersurface of the coracoid. So the 3 standard releases I do. And once I release it, then I do a reduction again. Once I release a post-release, I do a post-release reduction again and check for the mobility. Now, if you see in this particular video, the tendon is mobile. Initially, the same tendon is not coming so easily, but after all these releases, the tendon is coming so nicely onto the footprint. Now, I'm sure I can do a double row repair with this kind of situation, even though it's a large tear involving both the supraspinatus and infraspinatus. After release, the mobility is good. Now, once the mobility is good, then I prepare the gradual tuberosity. I prefer to use a burr on a reverse mode and gently decorticate the gradual tuberosity. But doing this, you have to be careful in elderly, especially in osteoporotic women. By aggressive decortication, sometimes you can end up in having a improper anchor fixation or anchor pull out, etc. So in those patients, I don't decorticate with a burr. I use a curette to remove all the soft tissue, and then I use some a bone awl to make some microfracture holes, like the Crimson Duvet effect, to increase the bone to tendon healing. Now, coming to the anchor insertion, the 3 points. Number 1, bring the arm into adduction. If you're using a traction, release the traction and bring the arm into adduction. This gives a better angle of insertion. And then slight internal external rotation can give you a better angle of insertion. And then use a needle to, here in the lower picture, you can see there's a needle going there, there's a spinal needle. Use a needle to locate your anchor insertion point. And once you're comfortable and the anchor insertion is close to the cartilage, then make a nick there, give a nick there and pass your anchor there. So this is a posterior medial anchor here. And then this one is a posterior, there's a posterior medial anchor and then an anteromedial anchor. 2 anchors is a standard technique we use. Rarely I use 3 anchors in the medial row when you have a massive tear involving the infraspinatus and teres minor, something like that. But majority of times using 2 medial row anchors is sufficient. So 2 double load anchors in the medial row close to the cartilage. And once you do that, now you have to pass the sutures. Now passing the sutures in the cuff, either you can use different devices. I prefer to use an AccuPass kind of device, and sometimes I use a simple LP needle, lumbar puncture needle, to pass the sutures. And with the easiest thing and least traumatic way of passing the sutures in the cuff, especially in elderly individuals with macerated cuff tissue, etc. I don't want to use any bigger instrument like claver hook. But if the cuff tissue is good, you can use a claver hook kind of instrument to pass the sutures. You can use a instrument like anti-grade suture passer, like a Scorpion or a first pass suture passer kind of thing. And again, this is this is also less traumatic way of passing the suture. Claver hook, I used to use in the initial part of my practice, but last 5-6 years, I've stopped using claver hook unless it's a young individual with a good cuff tissue, because it makes a big hole in the cuff. And once you pass these sutures, that means you have 2 medial row anchors. That means you have 4 pairs of sutures in mattress fashion going through the rotator cuff. Once you do that, you can start tying the knots. And biomechanically speaking, it is wise to tie all 4 pairs of sutures, but we are concerned about strangulation of the tendon. We're concerned about a type 2 failure of the rotator cuff. So what I do in my practice is that out of the 4 pairs of sutures, I tie alternately. That means 2 pairs I tie, 2 pairs I don't tie. I leave them without tying, and then load them into the lateral row of anchors. But again, you can choose to use suture anchors. Now the new suture anchors with the suture tapes, which you can give you the option of tying knots, or even without tying knots also you can use the suture tapes, and which gives a better compression than a suture, fiber wire fiber suture, simple suture. A flat compressive force with a suture tape is possible, and we can use the suture tapes without tying knots also. Once I tie the knots on the middle row, this is the final picture here. So the tendon is well reduced. You can see some of the sutures are tied and some of the sutures are not tied here. This white suture is not tied. So I don't tie all my sutures. I tie them alternately. And then once that is done, then we'll go for the lateral row anchor insertion. And then here I load these sutures into the lateral row knotless anchor. And this is the first anchor. This is the anterior lateral row anchor. That's going in there. And I use a suture manipulator to keep the tendon reduced while I'm putting my lateral row anchor. You can use the suture manipulator or grasper to make some minor adjustments of the reduction. And once you're comfortable, you can put the anchor in a knotless anchor. There's the first anchor going in. And I repeat the same. I load the remaining sutures in the posterior anchor. This is the posterior anchor, posterior lateral row anchor again. So you can do different configurations. You can crisscross, you can do different types of box pattern, and multiple types of configurations of suture management can be done here. Now, sometimes at the end of the repair with double row, you may be left with a small dog ear. If there's a dog ear, you can use a retention suture in the knotless anchor. Knotless anchors do come with this retention suture, and that suture can be used to correct the dog ears. Here, if you see, this is the end of the repair. I've used one retention suture to correct a dog ear. In spite of that, there is a small dog ear anteriorly, but I do not put too many sutures in the cuff. I am against doing too much rigid repair. So I left it like that, but most of the times a small dog ear, it doesn't matter. And this is the intraarticular view. The previous one is the extraarticular view. You can see here the bursal view. This is the end of the repair here. And this is the intraarticular view. You can see the humeral head here and the cuff is well reduced. Occasionally you may find the sutures are slightly lax, but it's okay. It doesn't interfere with healing so much. One important thing is that we should not try to do we should try to do a repair which is under high tension. Don't pull the sutures too tightly and try to put in the lateral anchor. So it's not recommended. Even though by being orthopedic surgeons, we want to fix everything very tightly. You have to understand this is a tendon, and too much of tension can lead to some improper healing. Now, this subscapular repair, subscapular stairs are less common compared to supraspinatus and infraspinatus stairs, and they do come as part of a massive tear pattern wherein both the supraspinatus and infraspinatus involved along with subscapularis are what we call as anterosuperior cuff tears, wherein the subscapularis along with anterior part are complete supraspinatus involved. And rarely we do find isolated subscapular stairs. Again, the pattern of repair is the same. I put a traction stitch in the subscap, and then I do certain releases. The first thing I release is the rotator tendon tissue, which mobilizes the tendon. At the same time, this rotator tendon release will give me a way to pass my sutures and suture anchors, etc. And the next release I do is from the coracoid. I release the upper subscapularis from the subcoracoid region. So the upper subscap, there's a coracoid here. I release it completely. So the upper subscap becomes mobile. And then I release the posterior aspect of the subscapularis from the anterior glenoid. That means I release the capsule here, anterior capsule, and the middle glenohumeral ligament, and so that it will mobilize the subscapularis. And rarely in retracted tears, I do release the subscap from the anterior surface, especially from the conjoint tendon. And in this particular scenario, we have to be careful to go and identify the axial nerve, and then you stay lateral to the axial nerve so that you have to protect the axial nerve there. So there's the anterior release. So I release it from posteriorly, I release it from anteriorly, I release it from the superiorly from the coracoid. So 3 releases we do for subscapularis. Once I do the releases, then I do a trial reduction of the subscap, and with the traction stitch. And when I'm happy, I put 1 or 2 anchors, and this tear I have put 2 anchors. And then again, you can use different devices to pass the sutures, and you can tie knots. Once you take bites, you can tie knots, and then this is the end of the repair. So this is the intraarticular view you can see here, and this is the subscap, nicely repaired. And of course, there's a small gap here. This is the supraspinatus tear, anterior supraspinatus torn. And after repairing the subscap, I have repaired this supraspinatus with a single anchor. Remember, when you have a combined tear of say subscap and supraspinatus, it is always the subscap which should be repaired, and then go to supraspinatus and infraspinatus, not the vice versa. And because the mobilization of subscap and release of rotator tendon tissue will give some mobility to the supraspinatus and infraspinatus also. So always start anteriorly and then go posteriorly. And of course, Dr. Yugal has covered it nicely. If you cannot repair it easily, you have tried all releases and you tried different tear patterns, everything, but in spite of that, the tendon is not coming to the footprint easily. So what should you do? A tensionless single row repair is better than a double row repair. That means if my tendon is not coming to the footprint easily, I won't do a double row repair. Instead, I choose to do a single row repair. Sometimes even a single row repair is also difficult because of underlying tension. Then what I do is that I do medialize the footprint a little bit, up to 1 centimeter. Also, I can denude the cartilage. I medialize my anchors more, and then repair the to the medialized footprint with a single row pattern. And of course, sometimes I do biceps augmentation. I do this when I can repair the infraspinatus, but the supraspinatus is retracted, it cannot be repaired. Then I use the longer biceps as kind of force couple or a static force couple kind of technique, where I use the longer biceps and repair it on the footprint anteriorly, and posteriorly I repair the infraspinatus. That means I restore the force couple and I don't have any supraspinatus tendon there. So I use the biceps instead of supraspinatus for the force couple. And these patients I've done a few cases and they're doing well. But I never do biceps augmentation when the infraspinatus is not repairable. Of course, Dr. Clement is going to talk on this biceps augmentation soon. Now, rarely I do a partial repair like the force couple mechanism described by Burkhardt. where I repaired the part of the infraspinatus posteriorly and part of supraspinatus anteriorly, wherein we restore the forescapul, and especially in elderly individuals, this gives good pain relief and also increases the range of motion. But of course, this cannot recover your strength. This is a kind of adjustment treatment in elderly individuals who are low demand. And in totally reparable repair tears, as Dr. Yugal has told you already, you can do tendon transfers like latissimus dorsi or a lower trapezius transfer for posterior superior cuff tears, and a pectoralis major or a anterior latissimus dorsi transfer for subscapularis irreparable subscap tears. And I did few latissimus dorsi transfers, and I did 2 pectoralis major transfers till now, because the irreparable subscap tear is a little unusual scenario, but I've done maybe around 15 latissimus dorsi transfers. And superior capsule reconstruction, which is the recent trend now, and I use fascia lata for the superior capsule reconstruction. Even though I sometimes use xenograft, nowadays I use a fascia lata graft, even though there is some morbidity for the patient, because the healing of fascia lata is much superior than a xenograft, as shown by some of the literature. And in-space balloon is not available in India at this moment. And reverse shoulder replacement, as I told you, in very elderly individuals with total pseudoparalysis, that means they cannot lift their shoulder like not more than 10-20 degree. Total pseudoparalysis in elderly individuals like 70 plus, and even without arthritis also, because we have to give them self elevation. And I don't think anything else in working these kind of chronic retracted tear patients in elderly individuals. I go for a reverse shoulder process. I have done few patients, maybe around 5 patients of reverse shoulder process in irreparable tears. Thank you.
Thanks, Chandrashekar. You can stop sharing your screen. Very nicely covered tips and tricks. How do you manage osteoporotic bone situations? Your tips on that.
First thing, this is a very difficult thing to answer, because we are dealing with the patient. Patient comes to you with osteoporotic bone. Now, one thing I noticed is that the bone near the bicipital groove anteriorly is a strong one. Okay. So I never had any major problem with the anterior anchor, anteromedial anchor, you can say. But the bone near the posterior medial anchor, that means posteriorly, is majority of times is a problem. Now you can use a large anchor, which you have some 6.5 anchors available. Number one. Number two, sometimes you can choose to use an anchor like a helicoil anchor, which has a mechanism which once you insert, the pilot hole you make is smaller, and once you insert the anchor, it kind of springs back. So this kind of anchor is also useful. And again, the new knotless anchors, all suture anchors, again, I haven't used many for the cuff repair, but they say that because you're making a small pilot hole, and whereas like 1.9 or 2.3 mm of hole, and then when you pull the anchor and the suture material bulges, that bulges up to 5 to 6 mm in width. So they say it can be used in an osteoporotic anchor. This is one more thing I have observed. But again, sometimes there are rare occasions where I cannot use a medial row anchor because of the very osteoporotic bone. In such scenario, I have used a direct lateral row anchor and repaired it.
Okay. Any other questions from the panel? I think we'll have some more discussions at the end of the last talk. So if there are no more questions, we'll have discussions at the end of my talk, which is going to be a technical one. So I'm going to start sharing my screen now. Once again, good evening, everyone. We're going to see how you can include the biceps tendon in your rotator cuff repair to augment your technique of rotator cuff repair. So however good you may be technically, better implants with better instrumentation, still we face considerable challenge in repairing rotator cuff tear, because we have having a lot of biological challenges like age, tissue quality, retraction, re-tear, and also technical challenges like suture cutouts, poor healing, as well as some of the patients can present very late in the stage with arthritis. With this, we have an approach of classifying our rotator cuff tears into 3 groups, which are easily repairable, where you can do any technique which you are comfortable with and get away with it. And then, of course, there are irreparable tear, which have some salvage solutions. But the one which troubles us more is what I call as a repair at risk. These are the patients who typically are slightly more elderly. They present with poor tissue quality, tissue chronic conditions with traction, so on. So irreparable, as discussed by the previous speakers, we have so many options. We prefer to offer tendon transfers in young patients. Superior capsule reconstruction, excellent procedure. You can use a fascial lata or dermal allograft or the locally available longet of biceps tendon, typically indicated for elderly patients with weakness without any arthritis who have some elevation. And reverse shoulder is indicated for people who have severe pseudoparalysis and also painful arthritis. Coming to the irreparable cuff tear, the superior capsule reconstruction with either fascial lata or dermal allograft, these tissues are actually bridged between the greater tuberosity as well as to the glenoid margin. They serve as a static restraint which prevent the superior migration of the humeral head. They keep the humeral head depressed, allowing the deltoid to elevate the arm. So they basically this static restraints on top of the shoulder, they re-establish the fulcrum for the deltoid to act. So this is the principle of superior capsule reconstruction, and a lot of studies show improved function as well as improved pain relief following these procedures. At the same time, if you look at the anatomy here, the biceps tendon is very closely associated, almost parallel, you would say, to the anterior aspect of the rotator cuff here. And it also extends from the superior labrum, and more than 50% of longet of biceps tendon is attached to the superior glenoid tubercle there. And there is a thinking, why can't we do a superior capsule reconstruction like a graft using the longet of biceps, if you can detach it distally and put it in the footprint of rotator cuff, especially when you can't do rotator cuff. And a lot of studies have shown that this can be done along with a partial cuff repair as shown here. So we have been, of course, reverse shoulder is for the end stage irreparable cuff tears. And when it comes to the cuff tears, which can be repaired, but there is a great risk of failure. So the strategies which we should ensure is do a tension-free repair, even it is a medialized repair, attach it to the medial border of the footprint, or you can extend the medial footprint by taking out the cartilage 5 to 10 millimeter medially, and then you can attach the tendon there. And if you are using these elderly cuffs or poor, and your sutures can easily cut through, and you may want to consider a configuration of sutures which will prevent the sutures ripping out. They are called ripstop sutures. We'll be seeing some patterns later in the slides. And in this particular case, I'm showing I used what is known as load sharing rescue sutures using fiber tape. I'll show it how it can be done. And many times these poor tissues can be augmented by including the longet of biceps in the repair. So these are the strategies which we follow in the management of rotator cuff repair, which can be done, but which has got a severe risk of failure. So when you're going to use biceps for augmenting your rotator cuff tear, you have to make sure that the tendon of the biceps is good, or at least has a reasonable quality without any tears or fraying. And also the rotator cuff should be able to brought at least to the margin of the footprint. The advantages of using longet of biceps is it is locally available. It adds collagen to your repair, and it has got a load sharing effect. It has got a static humeral head depression, which can share the load from the active humeral head suppression, which is a function of supraspinatus. So I think if the biceps tendon is acting initially, it can reduce the loads being to which the repaired supraspinatus tendon will be subjected to. Hence, it has got a protective effect on the rotator cuff tendon. And even if your rotator cuff tear fails because of the poor tissue quality, still the reattached biceps tendon can have a function like a superior capsule reconstruction, and thus it serves a fail-safe mechanism for your rotator cuff repair. So let's go to the case example here. This is a 79-year-old male, a doctor practicing gastroenterologist. So he comes with a 3-month-old pain and weakness of the left shoulder. He's got active elevation and a weak external rotation. But you can see in this picture, there is a good amount of retraction here. And one should not be discouraged by looking at this amount of retraction. It may be a U-shaped tear, as pointed out by Chandrashekar, where the anterior L shape, which usually goes on to become U-shape, this part may be retracted behind. So you may be able to bring the tendon posteriorly to cover this defect. And also you can see in the axial sections, there is a good subscapularis tendon, which can be seen here. And in these cases, it's very important to look at the amount of fatty infiltration. You can see here in this oblique sagittal sections, the muscle is small, but the proportion of fat in the muscle is less. So it is almost grade 1 or grade 2 degeneration, definitely not 50%. So it is not the amount of muscle. The muscle may be thin in elderly people, but the amount of fat in the muscle which is seen, that is very important. If it is more than 50%, it is called a grade 3 degeneration, which poses risk for your repair. Once again, these are the coronal sections. So we were a bit skeptical because the patient was aged and he presented with moderate weakness, and we were having doubts whether you'll be able to repair, and even if you are able to repair, would it fail? So first and foremost, these are very important. You should not use just simple side-to-side sutures here. As you can see here, all the mediolateral sutures are in line with the fibers of the tendon here, which can easily pull out. So if you are using a double row, doubly loaded suture, just a minute, double loaded suture anchors, you may want to use one pair to do this horizontal mattress here, which is across the tendon fibers. And then the side-to-side suture can go beyond it and comes above this suture. So this horizontal mattress suture here will prevent the second sutures from coming out. So this is the ripstop configuration, which is commonly called as modified Mason-Allen sutures. So this is very important to use in these cases of poor tissue quality. And second thing, what we used in this patient is a rescue suture. Before I inserted passed the sutures from the medial row anchors, what we did in this case was we passed a fiber tape from top to bottom, then bottom to top. And after the medial row is attached, this suture was taken out and fixed onto the lateral part of the greater tuberosity. So you can see there is no tendon which is getting attached here. This is not a typical transosseous, but this suture supports the tissue here. So this is load relieving rescue sutures. In case the medial row anchor fails also, you have a mechanism of this fiber tape which is connected to the lateral row. So this is a rescue suture which we used in this case. And in the next few diagrams, I will show you how we plan. So this is a slight modification of load sharing ripstop by Burkhardt. And the steps we use for this Mason-Allen suture is first we inserted the tape beyond the point where you're going to place the sutures for the medial row, and then the medial row anchors are inserted. And this pair, the violet pair, goes front and back, anterior and posterior, which will form the horizontal mattress. And one limb of the next suture is taken medially. So this will form the mediolateral suture. The next step is to tie the horizontal mattress first. This is a ripstop suture. And then the mediolateral suture is tied on top of this. So this first suture will prevent the cutting through of the mediolateral sutures. After the medial row anchor is inserted, the fiber tape from the medial part of the tendon is brought out and is loaded into a lateral row anchor and fixed onto the lateral aspect of the greater tuberosity. So this was the construct which we planned considering the age of this patient. We'll go through the surgical video here. So this is a view from the joint showing a big rotator cuff tear on top. You can also see some arthritic changes, but it was totally symptomatic. You can also see there is a grade 1 tear of the subscapularis, and this is a rotator interval being released. It's very important to have a good functioning subscapularis that will reestablish the force couple, and it can support the function of supraspinatus. Here we are inserting the double loaded anchor, And normally for grade 1 lesions, a single suture is enough. The suture is tight, thereby reducing the subscapularis to the footprint. And I prefer to do my surgeries in lateral decubitus. This is a view from the subacromial area. You can see a lot of fibrosis. And you can also see the tendon is not avulsed from the bone, it is avulsed slightly away from the bone. And the next step after clearing bursa is to clear the undersurface of the acromion, and then clearance of the footprint is done. You can see a considerable amount of tendon is left attached to the footprint. So it's very difficult to bring it all the way out to do a double row cuff repair. You can see here it is coming to the medial part of the footprint. And once again, you can see the biceps here. Now the tuberoplasty is done. So this clears out the irregularities as well as produces a good healing bed of bone. You can see the biceps tendon. You can see the anterior border of the cuff here. And here you can see before the footprint preparation and after the footprint preparation. Now the biceps tendon is checked for mobility. And with the use of a lasso, a nitinol loop is passed through the tendon for keeping traction sutures. You can see one of the fiber wire sutures is loaded into the tendon. With the use of these traction sutures, you can manipulate the tendon. So the anteriormost double loaded suture anchor is inserted in the anteriormost and medial part of the footprint. And this is the anchor which goes inside. And also you're inserting a second anchor, a 10 mm from the first anchor. And now the biceps tendon is pulled with the traction sutures, and using a scorpion device, one of the sutures from the anchor is passed. And now with a lasso suture passer, another pass is made through the tendon. The same suture which was inserted into the tendon is reloaded. So it is passed 2 times around the tendon. So this prevents easy cutout of the tendon, and it can lock the tendon nicely to the suture anchor. Now the tendon is pulled out, and once you are sure that length is adequate, you can use an arthroscopic scissor to divide the tendon here. The tendon division is completed. Now the tendon is brought to the footprint, and it is tied to the first suture from the double loaded anchor, anterior anchor. Now you can see already it is in good tension, and now it's functioning like a superior capsule reconstruction tissue. The sutures are cut here. And next we are going to do a rotator cuff repair above. So you are checking for the mobility. You can see the anterior limb is not mobile, but the posterior limb is very much mobile. So this should make you suspect an anterior L-shaped tear. So we are going to use some margin convergence here. So I'm going to use a scorpion device to pass one suture into the anterior leaf and one posteriorly. The fiber wires are taken out through the posterior portal, and the knots are tied. As you can see, it nicely brings the cuff tissue close to the footprint. Initially, it was looking like a big tear, thinking whether to use 3 anchors, but now it is looking like these 2 anchors should be more than sufficient. And the margin convergence sutures are cut here. And the sutures are passed for the anterior cuff repair. The anterior edge is fixed here. And then these are the rescue sutures. 2 fiber wire ends are passed anteriorly and posteriorly, and they are taken out of the anterior portal and parked. So these are the fiber wire sutures, and we'll come back to it at the end of the procedure. Now the sutures from the second anchor are passed. So this is and lasso suture passer is coming from the posterior portal, and the nitinol loop is delivered under the cuff there. And you can see one of the violet purple threads are taken out anteriorly. And this is a penetrating device which comes and picks up the second purple wire. As you can see, both the purple wires are taken into the cuff substance, which will be used to do the horizontal ripstop suture here. And you can see this is the horizontal mattress ripstop over the cuff tendon. The sutures are cut. On top of it, the blue tiger tape is used to do a mediolateral reduction suture here. And now we are exposing the lateral aspect of the greater tuberosity to do our lateral anchors. Now the fiber tapes which have been passed under the cuff are loaded into this anchor. This is a drill hole being made for the swivel lock. You can see the fiber tapes are loaded into the swivel lock, and the lateral row anchors are inserted. So we have another suture using fiber tape, but which is fixed onto the lateral aspect of the GT. So it is a combination of two medial row anchors and one load sharing rescue sutures as a lateral row sutures. This is followed by a little bit of acromial smoothing. I avoid doing aggressive acromioplasties. And this is a view from the top. You can see the biceps going along with the rotator cuff, and you can see the entire defect has been closed. And surprisingly, we thought this patient may have a lot of pain, but did not have any pain. So before you undertake any cuff tear, look for warning signs, whether the patient has got severe pseudoparalysis, whether one tendon or more than two or one or two are involved. Look for fatty infiltration, look for acromiofemoral interval, look for severe mediolateral traction and adhesions. So these are the warning signs you have to look for. And always take care and plan your repair properly when you are facing a repair which is at risk of failure. It's very important to mobilize the tendon for a tension-free repair. And load sharing and ripstop suture configuration can be very helpful, and one should be aware of all the configurations. Always consider biceps tendon augmentation if the tendon is healthy and available. Once again, thank you very much for your attention. Chandrashekar?
Yeah.
Yeah, you're.
So you have used one suture into the biceps, is it?
Yeah, one suture, but
And
two
then,
passes.
The other suture for the apex of the tear.
Yeah, yeah.
So from the anterior anchor.
Yeah, yeah.
The posterior anchor you use it for a ripstop kind of a configuration, and an additional load sharing you have kept.
Load sharing you have taken, yeah. But the scenario is changing from arthroscopic surgeons being biceps killers.
Yeah.
I know that in Italy, they used to say, when do you want to take biceps? Within 2 minutes, they say. When you ask about indications, they say about timing. But what is the current scenario of respecting the biceps and augmentation?
I think, sir, I still do the same. I always do a anatomy whenever it is feasible and possible, except in relatively younger individuals who are less than 50, or muscular individuals where you can have a Popeye deformity. Otherwise, I always do a biceps anatomy. Now, coming to the recent usage of biceps augmentation, I am doing this is last 1 year now. Whenever I have a deficient anterior cuff tissue, as you have shown here, the posterior cuff is good, but anteriorly there is some deficit there. So in that scenario, I'm using this long biceps as a kind of force couple or an augmentation for the anterior cuff. I think we have participated recently in one of the webinars where I think Dr. Park from Korea, he mobilized the long biceps and brings it to the center of the greater tuberosity and uses it almost like a superior capsular reconstruction. I haven't done that because I believe at least a long biceps is not such a large tissue, or the width is not so much to cover the entire footprint. So I use it for patients with loss of tissue on the anterior anterior part of the cuff. So where you can bring the infraspinatus properly onto the footprint, I repair the infraspinatus, and the anterior tissue, I use the biceps alone, or along with this remaining supraspinatus tissue as an augment, I use it. The same thing you have done now. So that's how is a biceps of course, is a static thing. And anyhow, we're going to cut the biceps. We're going to do a biceps anatomy. Why not use the biceps tissue to augment or repair? So it's a good thing.
Yeah, we always divide biceps because we don't want any pain in the future, right?
Yes.
But which is the source of pain? Because in this cases which we have done biceps augmentation, they didn't have any pain. Because I think the source of pain is from the groove,
yeah,
right?
That's what. You cut it distally. The pain is in the bicipital groove. So you have cut it distally, and then there should not be any pain. Or else, sometimes some surgeons, what they do is that they release the groove completely and mobilize the longer biceps, I mean inferiorly also, and then reposition it and then fix it on the greater tuberosity. But if you don't release in the bicipital groove and then you fix it on the tuberosity, then it becomes a problem. So here in your technique, you are cutting it distally. The same thing which I do. Sometimes I do put 2 sutures, actually not 1, but 2 sutures for the biceps augmentation from a single anchor. Or sometimes I used a triple load anchor. 2 sutures I use it for the longer biceps and 1 suture I use it for the anterior cuff. So that kind of scenarios I have done. But because we're cutting it distally, I think patient, it's like a biceps anatomy at the same time. The patient should not have any pain.
But the tension in the biceps is the main thing. If it's too lax, it is going to be useless. And if it is too tight, probably it may fail, or it can lead to pain or restricted mobility.
So what I say is that probably it is working like a soft tissue spacer, just like the balloon. The biceps tissue probably is maintaining the acromial distance. It's not necessarily it is functioning in a static manner or it's functioning in a dynamic manner, but it's functioning to maintain the space as a kind of spacer. That is also possible. And second thing is that when I do a biceps augmentation, I do it like a superior capsular reconstruction principle. I keep the arm in 30-degree abduction and then I tighten the sutures. So that's what I take care. But apart from this, just by having some soft tissue there, forget about there is biceps or cuff, whatever it is, a soft tissue probably is having a smooth surface for the acromion and probably preventing the acromial impingement. So that is one of the mechanisms. Probably it may be helping the patient. So we can as well use the biceps in this kind of scenario to augment our repairs.
So there is a question from Bhupesh. Do you have any problem with shoulder pain, especially during adduction after doing biceps augmentation?
I haven't done many. Probably I have done around 5-6 cases, maybe less than 10, not more than that. But I didn't have a problem. I didn't have a problem because especially when I do the augmentation, I follow this principle of superior capsular reconstruction. I keep it in slight abduction, 30-degree abduction, and then same thing what I do with the superior capsular reconstruction. But it is something new, and probably unless I see some more, I cannot tell you for fact. But at least my patients whom I did this biceps augmentation, they're doing well, no problem at all.
Any tips on rehabilitation? As it changed in the last few years, do you give sling or in a tension-free repair, you treat them without sling?
When there is a tension-free repair with like double row repair, I can do in a standard fashion. I do give sling to all my patients. I don't leave them I don't leave anybody without sling. I prefer to give an abduction brace or abduction acceleration brace sometimes. And when I do a proper repair without tension in a double row fashion, I can ask them to leave the arm without sling in the morning time. And while sleeping, while traveling, I ask them to put the sling. And then after 3 to 4 weeks, I start some passive range of motion. And then after 6 weeks, I remove the sling completely. And then I start some active assisted and active range of motion. But when I do some repairs like the ones we have done, like with the biceps augmentation or medialization of footprint, or I have done some repairs under slight tension, etc., I don't hesitate to immobilize the patient for 6 weeks in abduction acceleration brace, because for me, I know that the patient is going to develop some stiffness, but the stiffness can be addressed by rehabilitation, or if necessary, you can go for arthroscopic release after 6 months or 1 year as a second stage procedure. But the first thing you want is the cuff tissue to heal, because only once the cuff tissue heals, you can get the active elevation. If the patient has some stiffness, that can be managed with proper rehabilitation post-operatively, or if necessary, I haven't done it personally, but I'm always ready to do an arthroscopic capsular release for a stiff patient after 6 months to 1 year, if the patient is still unsatisfied with the stiffness. But idea is that once you have done a cuff repair, it is better to do get a proper repair, because if the cuff repair fails, your options are limited. Especially in elderly individuals, you have to go for a reverse shoulder process. Maybe in middle-aged and younger individuals, you can think of doing a Blatchmark's dorsal transfer or a superior capsule reconstruction, which are non-anatomical procedures actually. Even reverse shoulder is a non-anatomical procedure. What is your protocol? What is your protocol with
we have three groups of protocol. One is the patient who has got a very small tear, whom we operate for pain with nearly full power preoperatively. I give 1 or 2 weeks of sling, and then they are back to normal. There is no need for immobilization, but I tell them not to abduct the shoulder. And then the standard medium to moderate size, where we initiate the protocols like 6 weeks of sling with early initiation of passive range of movement. And there are risky individuals whom we do all this mobilizations, slight tension repair, or Biceps augmentation, very strict immobilization with some abduction below. So the exercise, everything gets delayed. So we have 3 categories of patients and 3 categories of protocol according to small, medium-sized tears and large massive tears. So that's how we classify.
Yeah, that's okay.
So anything to discuss? Otherwise, we'll close. So there are no more questions from the audience as well as from the panelists. I think once again, I thank all the participants. Chandrashekar, excellent tips and tricks, and Rotator Cuff. We all learned a lot from your talks. Probably the audience would have also benefited. And it is still a challenging field, and I hope this has been useful for people, and hopefully the recordings will help a lot of young surgeons later as well. Thanks all of you for participating, and I also thank the Biotek company for providing this opportunity with all their Made in India initiatives. I think they have a good role to play to make the cost of surgery cheaper in India. Thank you very much, guys. And with that, I'll call this meeting to end. Thank you very much.
Thank you.